All right, we're about to get started. So welcome to our very first happy hour at LASEM series. Thank you so much for joining, and we are absolutely overwhelmed by the fantastic response. So thank you so much for logging on and joining us. One of the things that we want to do in the current climate is our ability to socialize in cafes and restaurants and bars is really quite limited. And for those of you who have gone to conferences or professional development workshops, you know the conversations over coffee or over a drink are where you gain the most information. And when you get to access some fantastic and brilliant researchers. So what we wanted to do as a group at Trobe Sports and Exercise Medicine Research Centre was we wanted to recreate that. We wanted to be able to give you access to our fantastic world-leading researchers and give you the opportunity to ask questions and have a dialogue with them in a really non-threatening and inviting space. So welcome to LASEM's virtual bar. We're very lucky to have us with us tonight or this morning, depending on where you are. Our very first guest, Professor Jill Cook. Welcome, Jill.
Thanks, Sean. It's great to be here.
So I just wanted to briefly go through some housekeeping to start with. Now, as I said, this is all about you asking the questions and engaging and picking Jill's brain. So you should all notice in the Zoom function that there is a Q&A button. Can you please post your questions in there and we'll be able to answer from that. Now we do have a few considerations around that. Can people please not present a case study? So don't sort of present my patient is this. Try and frame it in a sort of more generalized topic. And the other thing in the Q&A function is that you can upvote for certain questions. So if there's a question that you really want to hear the answer to, upvote it and we'll make sure we will answer it during the session. So that was all for the housekeeping. So Jill, we're at the LASEM bar. It's my shout. What can I get you to drink tonight?
I'd love a Shiraz, please.
Pepper Jack, I'm assuming?
Yes, thank you. That'd be lovely. I have my Pepper Jack Grandad Scotch Fillet Shiraz here on the side and I'm enjoying it very much.
Fantastic. Well, cheers. I've got my gin here.
Cheers to everybody out there.
Yeah, cheers to everyone who's logging on. Maybe not the Europeans who are 8 a.m. Probably not morning. Accessible, appropriate for them to be drinking this early in the morning. So you do like your Shirazes and yes. the thicker the better. Where's one of the best spots that you've actually been able to have a Shiraz?
Oh, I think anywhere in the wine drinking areas of Australia. So Margaret River or Barossa Valley. I think when you taste Shirazes around the world, Australia makes really very big Shirazes. They're much more dense and much thicker than a lot of other places. And that's what I've grown up on. So I do like my Shirazes here in Australia.
Fantastic. So one of the things that a lot of people wanted to discuss with you was about your recent blog where you talked about the 10 most common mistakes that people make when treating lower limb tendon pain. So what do you think is actually the number one mistake most people make when it comes to lower limb tendons?
Yeah, I think it's pretty easy to answer this question, both from a research perspective and from a clinical perspective, because remembering that we do still see clinical patients, and that is making sure you have tendon pain in the first place. By far the biggest problem we have, as I say, both in research and clinically, is people presenting who have been diagnosed with tendon pain who actually have pain from another source. And that comes from sort of a tradition of being a bit dependent on imaging, where if you have pathology on your ultrasound or your MR, then your tendon must be your source of your pain. And then the second thing is palpation is always thought to give us great guidance as to whether the structure is causing pain or not. Now, I don't think it's just tendons, but for tendons especially, if you diagnose a tendon based on abnormal imaging and palpation soreness, you will be wrong 50% of the time. You may as well flip a coin. They are not diagnostic, and by far the most common thing when people present as research participants or in the clinic is they actually have pain from another source. So I couldn't emphasize enough that you need to be much better at diagnosing tendon pain.
Fantastic. And I think this sort of leads on to one of the other points that you made in the top 10 most common mistakes in treating tendinopathy was understanding what is high and low load for tendons, and that makes such a big part in your differential diagnosis. So I was wondering if you could share a bit about that.
Yeah, so if imaging and palpation soreness are not our diagnostic criteria, well, what are? And the two things that we use, and that's the crew here at La Trobe, so that's Sean and Ebony and Christian and Matt and all the people here that are in our research and in our clinical sphere, two things, which is localised pain that stays localised with load, and an increase in pain as you increase the load on the tendon. Now, to actually diagnose it, then you have to know what high tendon load is, and you have to know how to increase the load on a tendon. And of course, we're talking mostly here about energy storage and release or spring-like loads. So to give you a clinical example, for an Achilles, we start with a slow double leg heel raise, ask them how much pain they have and where it is. So is it localized? Then we go to a single leg heel raise. Where's your pain? How much is it? Then we go to a double leg jump. And of course, when we increase the speed of loading in tendons, we increase the load on the tendon. So that should increase the pain. And then we go to a single leg hop. And again, we're expecting to see an increase in pain. So if I went through that sequence of loading, we'd expect perhaps a 1 out of 10 pain, maybe a 2, but a big increase once we started the faster loads, which is more sort of 4, maybe 5 single leg hops. So that increase in pain with localized pain as you load the tendon is really, really important.
Yeah, brilliant. So had some great questions already being posted at this point. So I want to actually invite Niraj, because you had a question about progression in the initial phases of tendinopathy. Would you like to ask Jill that question? If you can unmute your microphone, here we go. Nope, that's okay. I'll ask it for it because he wrote some fantastic.
Hi, Niraj.
So Niraj asked, what should be the good progression in the initial phase of tendinopathy rehabilitation? From bilateral rehab to unilateral rehab while maintaining limited muscle tendon length is a question. What's sort of your guides for progressing really while considering load?
Yeah, okay. So if we say that energy storage and release is high tendon load, and that's a faster activity, then anything slow is going to be low level load for a tendon. So what we know from Ebony Rio's research and our group's research is that isometric exercises are great in the early stages for pain relief, but then we would very quickly progress to slow, heavy loading. So this is a heavy, slow resistance that Mads Kongsgaard investigated quite a few years ago now. And we would very much do that always single leg. So very much we see people in the clinic who've been given an exercise program. So it's rare when we see people for second opinions that they haven't been given exercises. It's often just that they're not being given enough or heavy enough exercises. So slow, heavy resistance is really important. Now, depending on the person, that might just be body weight loads. If it's an older person with an Achilles who just wants to walk, it may just be lifting body weight. But if it's a young athletic person, then it has to be gym-based and it has to be weight-based exercise. So the heavy, slow stuff, heavy in inverted commas for the person, is by far the best starting program for tendon rehabilitation. Single leg, isolated joint work. So not doing multi-joint exercises really expose the muscle tendon unit that you're trying to treat to heavy loads.
Exercise prescriptions just so important with any of this by the sounds of it. And I suppose one of the biggest concerns people have is finding out where that starting load is. So I wondered if you could give us some pointers about actually where to start, because people are in pain.
Yes.
So how do we consider that? How do we incorporate
Yes.
that? What's your sort of application on that?
Okay. So the first thing about tendons is that if it's slow exercise or isometric exercise, and even if it's heavy, it shouldn't be painful. So that's often a very good differential diagnosis. So for example, if you start somebody on a leg extension machine for their patella tendinopathy and it hurts them a lot, then I think you have to consider that you might have patellofemoral pain because patella tendons won't be affected by heavy, slow resistance. So that's a really good, important point. In terms of how much load, I think if I wanted to go to my second most important point, if the first one is get your diagnosis right, then the second point is load people enough. What we see is very much that physios, and I'm not just going to say physios, but medical practitioners, health practitioners who treat tendons are often frightened of loading them. They expect that pain's going to be the issue, that the tendon might be damaged, they might hurt the tendon. And the answer is none of that is true. And if you stick with very simple loads and TheraBand exercises, you're really not going to get the outcomes you need. You can really push these tendons very hard, very early. Now, what's hard, which is what your original question was, someone's got to be able to do it competently for the sets and reps that you recommend. So if you set somebody, let's just keep using leg extension because it's a nice, easy principle. If you set somebody a leg extension exercises with 50 kilos and they can't lift it, well, clearly that's not enough. But if you alternately do a leg extension machine with some red TheraBand and they can do 500 repetitions, that's clearly a silly exercise as well. So what we say when we start an exercise is you have to be able to do the prescribed sets and reps, and that's usually around about 30 reps in sort of sets of 4 or 5. You have to be able to do it well with control and be fatigued at the end and not able to do the next set. So say you did 6 lots of 5, then you couldn't do a 7th lot of 5 because your muscle would be too fatigued. So here in this early stages of rehab, we're talking about muscle, really, muscle rehab. And of course, we're loading the tendon, and of course, the tendon's getting stiffer. And of course, we're having very positive benefits through the muscle tendon unit. But really, this initial load is very much muscle-based.
Brilliant. So the first tip around moderation I got was give the people what they want. And there's been an overwhelming vote in terms of, we've been talking a lot about lower limb tendinopathy. And the question everyone's got on their mind, how much of this application of understanding tendon load and the progression principles apply to shoulder tendinopathy? So thanks for the question.
Look, you can never escape a tendon talk without talking about the shoulder. So first things, this is not my area of research. So people like Jeremy Lewis and Joe Gibson have done their whole careers looking at shoulder tendons. So I really don't feel that I should comment extensively on it. What I would say, if we talk about the upper limb tendons and we talk about whether they're an energy storage and release tendon, whether they use spring-like behaviors in activities, then there's a lot of upper limb tendons that we could apply these principles to. So certainly the medial and lateral elbow would be one, but again, differential diagnosis for lateral elbow tendon pain is very difficult. I think definitely proximal and distal biceps, especially long head of biceps at the proximal end. And I would argue potentially the posterior rotator cuff. I don't know about the supraspinatus or the anterior rotator cuff, but certainly the pecs, the lats, all our anterior agonist muscles to the cuff would be energy storage and release muscles, and you could use the same principles.
Yeah, brilliant. It's sort of one of those things is we talk about that we can lump even Achilles and patella tendon together, and a lot of our research has done it before, but there's still subtle differences that we need to consider at certain points, isn't it?
Oh, absolutely. 20 years ago, I said a tendon is a tendon is a tendon. And, that was my ignorance showing through. And as we do more research and we get a little bit more competent from a clinical perspective, we realize there's massive differences even in lower limb tendons. So the easiest way to illustrate this is to think about the populations that get tendon problems. And if you look at the patella tendon, it's young jumping men and pretty much only young jumping men. If you look at the gluteal tendons, it's old postmenopausal women. That's an oxymoron, but older women, usually postmenopausal. So there has to be a lot of things that are different about these two tendons for it to actually reflect across those two populations. And the Achilles is the really difficult one because it can occur in young jumping men or young sprinting men, and it can occur in older people. So it's very much a tendon that crosses a lifespan. So all of the risk factors, the things that make people present with these tendinopathies vary across life, vary with comorbidities. And we have to be very good clinicians, not only to work out the diagnosis, but to work out why the person is presenting and to work out the best treatments, because we can't give the same exercise program to a young jumping man and an older postmenopausal woman.
Brilliant. And just looking at the questions from one of our attendees, mentioned about even the different entities within the same tendon, and we're talking and mainly around growth developmental issues around, such as Osgood-Schlatter in the patella tendon.
Yes.
Do we think some of the principles we apply in the patella tendon can apply to Osgood-Schlatter or even the more apophyseal injuries that we see?
Yeah, I think the really important thing, it's such a complex question. Everything about tendons is complex, but this one's particularly complex because our apophyseal injuries, such as our severs in our Achilles and particularly around our pelvis, so hamstring attachment, AIS, rec fem attachment, all of those sorts of things are quite different. And they're a more benign presentation in that you really don't tend to get into trouble with those. If you just unload them a little bit, they'll often get better. The patella tendons, again, quite different. And some of the research that Elisa Rudavsky did showed that certainly at the proximal end, we don't have an apophysis. The distal end, we don't have an apophysis. So this is a maturation of the tendon through a cartilage growth plate. So not through a bone growth plate bone attachment. So not an apophysis by definition. And that changes everything that we need to think about, because if we disrupt that maturation process by excess load, then we can actually end up with a change in the structure of either the proximal or the distal end of the tendon, and that changes everything. However, having said that, certainly in terms of controlling loads, so reducing the load to a level that the tendon is happy with and the bone tendon junction is happy with, and then gradually increasing the load on that tendon is really important. What is also important in these younger kids with these apophyseal or growth injuries, tendon growth injuries, is that we don't rest them for the 6 months that the GP recommends, that we really get in and work out what load they're tolerant to and start to load them as early as we possibly can.
Brilliant. So just before, I think we're covering off the diagnosis and to pick up when the tendon and really the sort of features of tendinopathy really well. So before we shift to management and some questions around that, again, another really popular question is around hamstring tendon strains. So one of the questions is obviously we're seeing more intramuscular hamstring tendon injuries in the central tendon, with one attendee asking, does it actually exist? Or is it a diagnosis based on imaging?
It's certainly a diagnosis based on imaging. There's no doubt. I'm very old, and I remember when I was a younger practitioner that we used to have these hamstring tears that took a long time to get better. And I think probably what we were looking at was a connective tissue disruption in the hamstring muscle. So not just a muscle tendon disruption, but a connective tissue disruption in the tendon. What's really important, and we wrote a editorial on this in BJSM, so that was Cook, Bruckner and Purdom. So you can't consider this a tendon injury. So even though it's called a central tendon and it does exist as an injury, it doesn't act like free tendon. So if you really wanted good advice on this, I would go to the hamstring strain practitioners, the Rod Whiteleys of the world, who really understand hamstring strains much better than I do. But you can't apply the principles of managing a tendon when we're talking about a free tendon to an intramuscular tendon or connective tissue strain. They act differently. They don't store and release energy. They bleed. They are a completely different injury to the tendon injuries that our expertise is in.
And just finally on this, I think it's a nice segue to then get into sort of managing expectations and rehab. A lot of people have sort of mentioned that they feel that with these hamstring injuries, once they go through the rehab, there's quite a lot of residual tendinopathic pain. Is this something that we need to be, is this a common presentation that people see, or is it something that you've had a lot of experience with?
Oh, no. If it's an intramuscular tendon or intramuscular, I prefer the term connective tissue. So intramuscular connective tissue rather than intramuscular tendon. The reason is as soon as we use the tendon word, people change how they think about it and they change how they're going to rehab it. Treat it just like a complex or more serious muscle strain. That would be how I would talk about it. So in terms of tendon pain or hamstring pain post muscle strain of connective tissue, I'm really not the person to ask. What we do know from free tendon, certainly from a hamstring free tendon, is if you do a good rehab, that pain will settle very quickly and the person should be back to their activities.
Fantastic. So now to pivot into sort of rehab, which is a lot of the questions that we're getting. It's fantastic. One of the questions we had, and maybe this is a good opportunity to bring in one of our other panelists and fantastic researchers at the Trobe in Ebony Rio. So I think this is a question for both Ebony and Jill. Can you talk about the use of the metronome in rehabbing lower limb tendons? And
that's definitely a question for Ebony.
So welcome, Ebony.
Okay, so the premise of the metronome is that we did some research that showed you have changes to the way your brain controls your muscles if you have patella tendon pain. And the reason that's important is our loading exercises may not necessarily change that message from the brain. So every activity you do is a balance between your excitability, which you can think of like an accelerator, and your brake, which you can think of, that's your inhibition. So you've got this constant kind of drive, this acceleration and this brake. And what we saw in people with patella tendinopathy is they had changes to both their accelerator and their brake. So then what we started to do was look at research in the neuroscience literature, which had showed methods of changing the accelerator and the brake. And there's actually quite a number. But we were interested in methods that we could apply to loading, because at the end of the day, the best intervention, as Jill has summarised beautifully, is load, and getting your loads right and getting those loads individualised and progressive. So we were interested in techniques that we could combine with load rather than just throw all of the loading, the baby out with the bathwater. So what we did was use a metronome, which is a auditory stimulus, which your brain actually anticipates. So you're not responding to the sound, you're anticipating the frequency and the rhythm. And what that does is fires up all these lovely interneurons in your brain between your motor cortex and your auditory cortex and your frontal lobe. And in addition to getting the strength gains, because you're guaranteeing the time under tension for that particular exercise, you're actually also capable of changing your brake and your accelerator. So this is really exciting stuff. Well, I'm excited by this, but I'm a little bit of a nerd. But everyone on this call is a bit of a nerd, let's be honest. So that's how we use the metronome. We use it in both an isometric phase where people have that, that auditory cue, and we use it in the isotonic phase where, again, they have that auditory cue and it also paces the movement. And we then don't use it in the faster phases where we're not using load but applying more spring-like activities.
Sounds like do you think it's can you do one without the other? Can you do the metronome and not the strength training?
No, definitely not. That's a great question. So if you do an imagined contraction or some sort of technique which changes your brain, you will change your brake and your accelerator. But the reason why that won't be effective is what we know clinically and what we know from the research is that people have dysfunction. So they have weakness and their tendon needs load and the attached muscle and the kinetic chain, and frequently the other side need the rehabilitation. So if we don't actually address those deficits, people just won't have the capacity. So it is not all about the brain and just applying these techniques. It's fitting them into our best practice.
Brilliant. So we had a question around some sort of guides of what strength for normal. So Luke Nielsen, you had this question. I wonder if you wanted to unmute your microphone and potentially ask.
Yeah, thanks, guys. Can you hear me okay, Sean?
Hear you great. Thank you.
Yep.
Yeah. Thanks, Ebony and Jill. Just asking about what strength normals that you go off for lower limb tendinopathy. So that might be really all regions. So whether that's calf, quad, hip extension, hamstring, and yeah, just in obviously a bit of a guideline. Obviously, it depends on different populations, but just what you'll often use.
Yeah, that's a fantastic question. The problem that we have with this is just the diversity of people who present with tendon pain. And so it's going to be very population specific. So if you imagine an older person with an Achilles tendinopathy, we would expect them probably to be able to lift their body weight on that affected muscle tendon unit 20 times well. So good technique, right to the top, exactly how Sue Mays does it with the ballet. And there's videos on that. So that might be appropriate for that person. But if you had a sprinting athlete who had an Achilles tendon problem, then we would expect them to single leg heel raise their body weight plus their body weight, or plus even 1.5 times their body weight, 4 sets of 8 or something like that. And so it's very variable. So we would say for an elite population, 1.5 times body weight, single leg, 30 reps in sets for both the calf and for the leg extension. The problem that we have with the hip muscles is we can't measure it quite so well. So we have machines that have cables that have levers and cams and things. And so it's much, much harder to get a really good measure of what's appropriate for hamstring tendinopathy. For the glutes, these older ladies really just need to be able to sustain their body weight single leg with a relatively level pelvis and do it repeatedly so that they can walk comfortably and get up and down hills and things like that. But again, that's very non-specific, and I apologize for that, but they don't actually need much more than that. So it's a great question, and maybe we do need to quantify this a little bit better. One of the things that we do clinically that I think we could probably improve on is quantifying the loads that people are able to achieve when they are able to return to sport. But that gives you sort of some guidelines.
Brilliant. Thanks for that question, Luke. really interesting in terms of this whole issue with coming to normative values and the diversity that we see in tendinopathy patients. But I suppose not so much around what the normative values for strength we're looking for. What are some of the indicators that you look for in when you're trying to progress athletes or patients through the different stages? So from strength training to starting to get into energy storage to then that more sports specific loading. What are some of your guides around that?
Yeah. So that's another great question. So strength loading, so heavy, slow resistance loading doesn't cause us tendon pain if we have tendon pain in the first place. So we're really looking for strength outcomes there. And we can use the other leg as a guide in terms of trying to get close to what the other leg is capable of. Remembering that we're we're nearly always trying to load single leg and isolated muscle tendon unit. But we can use the measures that we talked about when I answered that last question in terms of 1.5 times body weight for a leg press, single leg for an athlete is a good base sort of guide. Once we get past that, and that, as I've said, is quite variable, once we get into the energy storage and release, so this is where we've progressed from the slow, heavy resistance to the energy storage and release type loads, where we start slow and we build up the numbers and we build up the speed with the intention of actually taking that right through to sport-specific type of loading. For that, we obviously are going to do that every second or third day because tendons need a little bit of time to recover. What we're using there as our guide is, aside from counting every repetition, so we really want to make sure that we're increasing the load very systematically, is morning after pain. So if I load today, say I'm recovering from my Achilles and my physio asks me to do 10 hops on my affected leg because I've done all my great strength work and I'm feeling like I'm strong now. Now I want to actually see if it's tolerant to those energy storage and release loads. If I do 10 hops today and tomorrow morning I get up and my morning stiffness is the same, then my tendon is happy. What I need to look out for is if I load it today, I do my 10 hops today, and then I get up tomorrow morning and my morning stiffness is worse. So it's either I have more longer stiffness or more intense stiffness. That's a reflection the tendon hasn't liked that energy storage and release loads. So my physio should alter that and say, okay, well, 10 was too many. Maybe we need to go back to our strength work for a bit longer, or let's try 5 and see if 5 is okay. And if 5 loads in a couple of days' time and you get up the next day and the stiffness is about the same, then the tendon's really happy. So you can then do 5 for a few days and then increase from there. And then the intention would be to get that progression right back up to those really sport-specific, activity-specific loads.
You mentioned a couple of times about sort of pain and sort of how much pain tolerance is your indicator for progressing. I was hoping you could potentially clarify by what you mean by pain and how much pain is acceptable during tendon loading.
Oh, now that could be the biggest, broadest question that's been asked tonight. Thank you for that. Okay, so I'm not a great fan of numbers out of 10. I know that there's some research in numbers out of 10 and that if it's more than this or less than this, then it's okay. I think it comes down again to the person. So very much if you think again about a young volleyball player with patella tendinopathy, they're used to playing with 5 or 6 out of 10 pain, and anything less than that's quite unusual for them, and you know, they go out and try harder and run more and jump more because they need their 5 or 6 out of 10 pain. So I tend to like using the person-specific type of pain. So for that young volleyball player, if their normal decline squat pain is, we're always going to be testing on some sort of standardized pain score. So if their decline squat pain is usually 6 out of 10, if it stays at 6 out of 10, then we can continue to increase load. If it goes to 8 out of 10, then that can be a reflection that you've overloaded. So I think a change of 2 or more upwards on a loading test is a good indication that the tendon is not coping. But I don't think you can actually say you should have no pain or, you know, less than 5 pain, all of those things. I think in athletes especially, and I think in a lot of our tendon rehab, not only do we not know how to load and we're frightened of loading these tendons, is we're constantly looking for zero pain. And the answer is zero pain is a very hard place to get. If you can get somebody's pain to a level where they can perform their activity and have stable pain that they can tolerate, then that's a good place to be. So for our volleyball player, it might be 5 out of 10 pain. For our lady who walks a dog, it might be 0 out of 10 pain. But if we constantly go searching for 0 out of 10 pain, then we often delay people getting back to their activity. We're often looking for something that perhaps we can't achieve.
Ebbs, you're a resident pain expert. Does the pain literature provide us any answer to this question?
Oh, can you repeat the question for me? I've been trying to keep up on the Q&A and respond to people, just seeing how much time we have left and knowing that not everyone will get their question answered. So I'm sorry that I missed it.
So Jill was talking about sort of guides where pain might be an indicator for progressing, and talking about how really zero pain shouldn't be our goal, but it's trying to be stable and manageable. Does the pain literature give us any other insights into that?
Well, actually, something that I learned from Jill and Purds really early on was one of the best things you can do is empower people and actually educate them about when to listen. And as you've heard from Jill tonight, the best time to listen to the tendon is 24 hours after, and knowing what loads are really safe. So really educating people around, you know, if you're doing a static load, if you're doing a slow load, that's super safe. So if you've got some discomfort at the time, that's actually okay. And people like knowing that. And if they don't know that, they're at risk of really underloading. So if we look at the pain literature, that actually fits in really nicely with the principles of, you know, graded activity and pacing and exposure and all of those concepts. But it just can't be generic. It's actually got to be specific to tendons. If you've got someone with Achilles tendinopathy, you can't just tell them to be physically active because, you know, it's good for them and it's good for pain in general. You actually need to be far more specific about, well, what capacity do they need to be able to do the activities that they want? So I think we need to combine what we know about the pain literature with the specifics of the person in front of us, and really avoid just generic advice.
Brilliant. I think with our last sort of 7 or minutes or so with this session, I think it'd be remiss of us to sort of not acknowledge that the world has changed. And changed in a big way in so many different aspects. And we've had some great questions around the fact that the global pandemic has actually stopped a whole bunch of people being able to access the gym, to being able to do their normal training, especially when we're talking about elite athletes. So any recommendations around conditioning our athletes, especially the power track and field athletes, any sort of guides with that in the current world?
This realistically frightens me to death. I think there was a fabulous study by Wood that showed that after the layoff in the NFL, they usually had 4 Achilles tendon ruptures. And after they'd had 4 or 5 months off, in the first 2 months, they had 11. And so tendons are so vulnerable to unloading and underloading. And what we know with tendons is if you sustain a constant load on a tendon, or the same load on a day-to-day, week-to-week basis, they do really well. So what frightens me is that these athletes are probably still training at home, but really not getting the loads they need on their tendon, and that there'll be a rush to get them back to high level loading because of, you know, the sports and the money and all of those sorts of things. I think not only are we vulnerable from a tendon perspective, but we're going to see hamstring strains and stress fractures and all sorts of things that will come because of this period of downloading before we reload. I think the smartest thing to do, I was talking to Sue Mays at the ballet today, she said they will do at least a 3-month training before they go back to any performance. Now, that's absolutely what people need to do, at least. But I think it's a luxury, and I think there's going to be a lot of athletes in a situation where their load changes are going to be too big for their tendons. But as I said, they're going to be too big for their muscles and their bones as well. So I think we'll see a plethora of injuries after this layoff.
Certainly going to make for some interesting time for a lot of physios and clinicians in sporting teams. So yeah, our thoughts are going out for them in that tricky time. And I think this is also a worthwhile opportunity to also talk about the options to potentially rehab patients while at home. And Ebbs, you had a paper on a technique for isometrics for patella tendinopathy. Did you want to quickly mention that?
Yeah, sure. So we looked at the ability to do isometrics for the patella tendon sort of on the road. And what we meant by that was people that didn't have access to gym equipment. So we used a belt, which was a continuous loop that people could put around something really sturdy and then place their legs into one loop either side. And that's based on Angle Bass's fantastic work in jumping athletes. So he applied this squat technique, the Catalonian squat, I think they call it. So you can look up that research. So it's based on doing a squat with an upright trunk where your tibias are at 90 degrees and it's much harder than a wall sit. So often people say to us, oh, can we just do a wall sit? And this is far more load on the quadriceps and the tendon in terms of how hard it is. And that's really important. A wall sit is just far too easy if we're talking tendons. So that certainly provides an opportunity. But I echo what Jill said. It's a really hard challenge.
Fantastic. So we've got 3 minutes to go, Jill. My drink's empty. I'm sure yours is close to being empty as well. So we're going to have
I won't admit to that.
So I think we've had a fantastic response in terms of questions. Your final tip, you talked about the 10 most common mistakes people made in the blog, but what is the one non-negotiable? We've got some fantastic clinicians that are brilliant thinking clinicians and will think this condition through. What's the one negotiable? What's the thing that they've got to consider at all costs?
I think, well, distill it down to a single thing. It's almost impossible. For me, the thing that you must work towards is restoration of function. And when we talk about function, as I say, it might be just being able to walk the dog, or it might be being able to sprint 100 meters at 10 seconds. We need to recover that. What we know with tendons is that if you have dysfunction, you often have tendon pain, and tendon pain causes dysfunction. So we get caught in this trap that goes around and around where the pain stops us performing and functioning. That then creates more pain, and around we go. What your role as a clinician is to break that cycle and restore function. And when we're talking about function, as Eb said, we're not just talking about tendon and tendon stiffness and tendon compliance. We're talking about muscle strength, muscle power, muscle endurance. We're talking about the kinetic chain, our anti-gravity muscles, if that's the ones we're using. We're talking about the other leg. We're talking about the brain. So gone are the days where we poke a tendon and scrape a tendon and, direct our tensions at the tendon. We're talking about function here. So it has to be holistic. It has to include everything that contributes to that athlete, that person being able to return to their activity or sport. And if you don't do that, you're not going to get long-term tendon pain recovery. If you do that, you're going to get these people better.
Brilliant. I think that's a great place to leave it off. So firstly, Jill, thank you so much for your time. And Ebony, thank you for jumping in and providing some context to some research and some clinical experience. But most of all, thank you for all of you attending. We have been absolutely overwhelmed by the response. This won't be the last time we do this. We will do it with other researchers at La Trobe, and probably we'll do it again with Jill at some time, because there's so many questions that we didn't get to and was unanswered. We have saved the questions and the chat, so we might pick a few of them out and respond to them on our blog. Can I suggest that you all follow the La Trobe SEM Twitter page, because that's where we will post most of our information about these sessions, as well as we will post this recording of this session. So get your fellow clinicians on board. I think that's all from a housekeeping perspective. Again, the Facebook page as well, we're doing some fantastic things. Our group are putting out some exercises on how to exercise in different ways from home. So definitely looking at the Facebook page for La Trobe SEM is a great place to go. So again, thank you so much for your interest and your attendance. It is greatly appreciated. And please look after yourself and your loved ones. Till next time, people. Goodbye.
Thanks, guys.